So 1, 2, 3, we can go live.
Good evening. Welcome to Ruma TV's lecture series on biologics. I think a couple of weeks back, I just had introduced about the concept of biologics and biosimilar, kicking start the whole series on different target-specific biologics. Today, our focus is on the first of the target on which the biologics got its approval, that is TNF. And it was the dream which we thought that if work on the TNF, probably we can get rid of the rheumatoid arthritis. I think I made it clear, dream remained a dream, because what we thought was the target was not the only player in entire rheumatoid arthritis and autoimmune disease. So that's why this whole lecture series is divided into 4 major components. First component is going to be on the basics of the cytokines. How do they really play with reference to autoimmune disease? What are the effects and what are the possible other effects will be covered in the first part. Followed by what are the molecules that are available with reference to the specific blocker. I think that will be covered by Dr. Vijay Rao. And followed by the clinical indications where it is approved, which will be covered by Dr. Ved Chaturvedi, and followed by the most critical aspect of any new drug or any drug which we use is the safety and the precautions that we have to take, especially when we are interfering with some of the key processes in the immune system, which will be covered by Dr. Ramesh Joyce. The first speaker of the day, Dr. Avinash Jain. He is finished his medicine, followed by DM Clinical Immunology from Sanjay Gandhi Postgraduate Institute of Medical Science. He is currently assistant professor in rheumatology at SMS Medical College Hospital, Jaipur, and happens to be one of the winning team member of the striking doctors who have really made a difference. And of course, he's also proactive in varieties of rheumatology and in various fields of rheumatology. He is currently sitting EC member of IRA, and he has various roles and awards to his credit. Without coming in between, I hand over the talk to Dr. Avinash. Avinash.
Thank you, sir. Thank you for the kind introduction and announcing me as a winner here in Rajasthan. So I'll start sharing my screen. Right. Yes. So I assume that the PPT is visible and it's going into the screen mode. Yes, lovely. Okay, great. So I think very interesting concept. Sir always keeps coming up with, there is no dearth of topics and lectures when he decides. And he has given me this responsibility on talking about TNF and anti-TNF, mainly the concepts. And, this is how the batting lineup looks like with asking me to open and being a test match. I have been asked to be like Dravid, boring, but at least some foundation I lay here. And the heroes will join and play the Sehwag and Kohli-like innings later. So, no disclosures. And pathophysiology, it's like this famous GOT. You simply do not walk into patho. You have to be mentally prepared, before taking the storm on head. So let me just quickly start with the story of TNF, the TNF alpha, the TNF inhibitors, and then we will gradually move on to the mechanisms, the various autoimmune diseases, why TNF alpha plays a very pivotal role, and what are the molecules which are available, and how do they really differ, minute differences between different molecules. Now, this was 2012. I did not have the courage to look for another decades of citations, but the number of citations on TNF alpha, anti-TNF alpha have been increasing. There are more than 10,000 reviews which have been published on this molecule itself, which speaks highly about the molecule. So it was way Caswell et al. They discovered this endotoxin-induced serum factor that causes necrosis of tumor, and hence the name tumor necrosis factor came up. And then 1984, simultaneously, Panicia et al. And Agarwal et al., they talked about human tumor necrosis factor, which was actually derived from a lymphoblastoid cell line. Hence they had also called it lymphotoxin. And this is how the SDS page looked like, when they had isolated this lymphotoxin protein, which was coming from the lymphoblastoid cell line. And gradually, over next almost last 30 years or so, the pro-inflammatory effects of TNF were being delineated. Their role as central endogenous mediator of endotoxic shock came up. And people started asking questions: how does this molecule work? What is its structure? What are the beneficial functions? Is it just beneficial? Is it harmful? Can it really be blocked? And in 1992, in a collagen-induced arthritis mice model, the impact of anti-TNF factor was shown, where the drug not just ameliorated the joint disease if they were pre-medicated, but even after the arthritis was induced, it had remarkable effect on this collagen-induced arthritis, where TNF-alpha plays an important role. This was also tried in sepsis, but unfortunately it failed, because we know and we have read how TNF-alpha is playing a role in sepsis. So this is, something, TNF-alpha was, the confusion was, how does it really work? Why is it that it is effective in certain situations? And in certain situations, it doesn't really work. I don't think we still have a perfect answer to it, but we will try learning the various mechanisms by which the TNF acts on the TNF receptor 1 and 2, the soluble forms, the transmembranous forms. Finally, in 1994, a very small randomized controlled trial of, I think, 23, 24 odd patients was done, where they showed the effect of TNF-alpha blocker in rheumatoid arthritis versus placebo. This was, I think, a game changer. And since then, there has been no looking back. And if you look at from 1998 to 2018, what has happened is the newer molecules have come up in the horizon: infliximab, etanercept, golimumab. Not just the new molecules. As we learned more about the disease pathogenesis, the utility of these anti-TNF blockers have increased, starting with rheumatoid arthritis, infliximab in Crohn's disease. Finally, in 2022, adalimumab got approved for RA. Gradually, the certolizumab, golimumab came into picture, and then the increasing number of indications from RA to psoriatic arthritis to AS, plaque psoriasis, polyarticular GIA, ulcerative colitis, and then there are lots of off-label use. They have been used in Behçet's, they have been used in uveitis, systemic GIA, hidradenitis, Takayasu arthritis, and so on and so forth, because TNF inhibitor was found to play a central role. So let us start with the basics. And when I say basics, I'll be talking about the TNF family, the receptors. We will be going through few slides on TNF receptor structure. How do they function? What are the downstream pathways? And then the mechanism of action of TNF-alpha blockers. So, this is the big family, the QB 7th edition. I really like that table, initial days when these things were not really making sense. This chapter on cytokine and cytokine family did increase the confidence partly. And though it's been more than 7 years, but I hope I'll be able to do some justice. So this TNF factor family includes the main villain or the hero is TNF-alpha here. And other than that, it includes CD40 ligand, which is very important for interaction, which is expressed by T cells, interacts with B cells, causes activation of the B cells, the T follicular helper cells, the FAS, and so on and so forth. The focus of today's, the main team today is the TNF-alpha, and there we'll be focusing more on that. What happens is TNF-alpha, which is made intracellularly, is cleaved by an enzyme called as TACE, T-A-C-E, TNF-alpha converting enzyme, and it forms a soluble biologically active TNF. We will see that there are two forms in the subsequent slides. What it does is this TNF-alpha forms a homotrimer, becomes active, goes on to activate TNF receptor 1 and TNF receptor 2, also referred to as P55 kilodalton protein, CD120A, and TNF receptor 2 is referred to as CD120T. This TNF alpha, like I mentioned, could be a transmembrane form where the chain is attached to the cytosol. The partly lies in the cytosol and is spanning across the cell membrane, and is important for cell-to-cell signaling and local inflammation. Whereas soluble TNF can act at sites remote from TNF producing cells. So I did like this figure, and ultimately I realized thoda sa complicated hai. I had hidden it, but somehow it has come up to expose the immunology part. But anyways, so these are, various theories. This was way back in 1995 when they talked about that the various mechanisms by which the TNF alpha, the TNF receptors might be acting. And at present, this is the theory that holds good. Looks complicated, but I'll walk through this figure with you. We'll first focus. So there are, two receptors: TNF receptor 1, TNF receptor 2, P55, CD120A, CD120B. Now, this is expressed on most predominantly on the macrophages, but number of other inflammatory cells. Major role, inflammation. As compared to TNF receptor 2, it is also important for host defense, tissue regeneration, and cell proliferation. And is expressed on neurons, immune cells, endothelial cells, and hematopoietic cells. Now, the difference between the two is one is more of pro-inflammatory and the other is striking a balance. This TNF receptor 2 is activated only by transmembrane TNF, as compared to TNF receptor 1, which is activated both by the soluble form. The soluble form, as I mentioned, is formed when the transmembrane TNF is cleaved by the stase enzyme. Now, why do we need to know? This is because when we will be just finishing our talk, we will see that the future therapies are now trying to target only this pathway. They don't want this pathway to get inhibited because this helps actually in tissue regeneration, cell survival. The newer molecules which are in the pipeline or are being discussed theoretically are focusing more here. What happens is this homotrimer is being formed. The TNF transmembrane or the soluble TNF will activate TNF receptor associated death domain. As a result of which, so let me show you a detailed figure here. What happens is they will bring this enzyme TNF receptor associated factor 2 and RIP. RIP actually stands for rest in peace. So this is being formed. This dissociates from the membrane and a complex 2 is being formed. This goes on to activate the pro-caspase into caspase, resulting in apoptosis. Now, you cannot have inflammation all the time. You have to have something anti-inflammatory. So what happens in anti-inflammatory is these cellular inhibitors of apoptosis will go and bind to this complex 1 and instead will activate C-flip, which inhibits caspase 8 and hence helps in preventing inflammation. So you see what was happening is this complex 1 goes on, separates itself after combining with RIP and TNF receptor associated factor 2, forms a complex 2A and 2B, activates caspase 8, causes apoptosis. There is another complex T which causes necroptosis, resulting in increased permeability of the cells and release of the materials which are inside the cell membrane. So this results in inflammation. So if we can block somehow either the receptor directly or the TNF alpha, we would be able to take care of this pathway and decrease inflammation. And that what actually forms the basis of the TNF alpha blockers which are available. Ultimately, what happens is because of activation of these downstream pathways, NF-kappa B, MAP kinases, AP1, there is increase in the cytokines, IL-1, IL-6, GM-CSF, chemokines, results in recruitment of these neutrophils, increased production of metalloproteinases, and ultimately this results in inflammation. This is basically the same thing. The TNF alpha, which is the villain, results in cell recruitment, results in activation of endothelial cells. They become more permeable. The fibroblasts are active. The synovial, there are fibroblasts like FLS, which are sitting at the center of RA pathogenesis. They all get activated by this TNF alpha. There is increased expression of VCAM and ICAM1, and I have few experiments which will show how this happens and what happens when TNF alpha is being given. So ultimately, if you inhibit it, what will happen is all these molecules will start decreasing. The cytokines which gets released because of TNF alpha, there is a reduction in IL-1, IL-6, GM-CSF, There is a reduction in chemokines which recruit inflammatory cells to the joint or to the lungs and various other organs in the body. There is decreased expression of adhesion molecules and hence decreased cell trafficking. There is decreased expression of VGF. The swelling hence decreases. That is how anti-TNF helps in decreasing the swelling by decreasing the permeability, by decreasing the expression of VCAM, VEGF, and so on and so forth. What it also does is it alters the Th1, Th2, Th17 phenotype, activates the T regulatory cells, and ultimately results in decreased inflammation. Just take, for example, this figure about infliximab. The immune cells are they result in death of these immune cells. Why? Because they have an Fc ligand. This molecule infliximab, which is acting against TNF, they have an Fc ligand. Fc mediated ADCC occurs, cell type cytotoxicity occurs, and there is apoptosis. The barrier function of endothelial cells improve because there is less expression of adhesion molecules, there is less VEGF, the permeability decreases, and hence the epithelial cell barrier improves. Very much what happens in Crohn's disease. In a similar way, the endothelial dysfunction, the fibroblasts which were causing scarring, there is improvement there. So by decreasing the permeability, increasing apoptosis of the activated lymphocytes and macrophages, they bring about decrease in inflammation and improvement in the symptoms. Now, this is an in vivo RA study where the authors had shown after giving anti-TNF, 1 mg per kg dose and 10 mg per kg dose, there was a decrease in this E-selectin expression, more marked decrease in 10 mg per kg dose. Similarly, what a beautiful experiment they did in 1994 using something called as Paulus response score, which is a 6-variable score. They divided the group into those who responded and those who did not respond and those who responded. Now look at this baseline E-selectin expression. The ones who responded, the E-selectin expression was close to the baseline only in 3 patients, and in the rest of the patients, it significantly decreased. Something similar happened with ICAM and the lymphocyte counts, which showed that the effect that those who were responding versus non-responding, there was actually change at the cellular level, at the level of these adhesion molecules and at the level of lymphocytes. Something very interesting. Now so this was basically, how the TNF is functioning, but we will come more into we will discuss a little more about the pathogenesis and few more experiments, how the TNF alpha blockers work. A beautiful figure which was published in 2019. Look at the TNF cytokine target and their role in so many diseases, rheumatoid arthritis. I think we all are aware, systemic GIA, Crohn's disease, ulcerative colitis. They are so effective in these group of autoimmune diseases, and they are all are FDA approved. Not just autoimmune diseases, people have shown their role and importance in osteoporosis, Rank-Langan, cancer, some inflammation happening in NAFLD or NASH, metabolic diseases, though they don't have a role as yet, but particularly in the left side of the figure, in the autoimmune diseases, they have a very important role. Starting with 2 prototype diseases, RA and psoriatic arthritis. The major source of TNF alpha in rheumatoid arthritis is macrophages to begin with, whereas in psoriatic arthritis, it is dendritic cells and macrophages. They will go on to activate the fibroblast, which will release lots of, cathepsins and metalloproteinases, ultimately resulting in cartilage and bone destruction. TNF alpha also results in increased IL-1 and IL-6 and increased migration of the leukocytes and permeability of endothelial cells. In psoriatic arthritis, they would activate the keratinocytes and result in psoriasis. So if we block TNF alpha, the activation, proliferation of fibroblast, the T cell repertoire, which is getting changed into Th1 and Th17, can be taken care of. This was the 2 very good experiments which were published in 2000. These are the synovial biopsies of the patients who had received TNF alpha. Look at the staining here. This is all TNF alpha expression in the synovium has markedly almost disappeared. Similarly, after giving TNF alpha blocker, the IL-1 alpha, IL-1 beta level decreased. And look at these gamma camera images of the joints which were captured after 5 patients who were given TNF alpha. Except for patient number 2, for rest of the joints, there is a decrease in the in the autologous radiolabeled granulocytes which were injected in these patients before and after infusion. The penetration, the infiltration of these cells it's almost like, real-time capture. You have given the drug and you look at these radiolabeled granulocytes markedly decreased. Something similar in the wrist joint, pre and post. Look at the joint after the TNF alpha blockers were given. And something similar they showed in the infiltration of the synovium lining. The CD3 positive cells, the CD22 positive B cells, the macrophages in the sublining and the lining layer, they all decreased after giving TNF alpha blockers. And then there have been lots of papers and reviews which talk about TNF alpha blockade resulting in decreased cytokine production, decrease in the infiltrating immune cells, the monocytes, macrophages, the T cells, the skewing of T cells, also helps in improving the anemia of chronic disease, increases T regulatory cells, inhibits the dendritic cells, and hence results in improvement of rheumatoid arthritis. Something similar with AS, IBD, uveitis, you name it, the TNF is there everywhere. The transmembrane TNF and the soluble TNF results in new bone formation, osteitis, enthesitis. You block them and you see that the inflammation, and in the long run, even after 10 years of disease, 10 years of therapy, people have started showing that the new bone formation is also getting impaired and in some cases reversed. Something similar in IBD, TH1, macrophages, activation is happening, the TNF alphas are being released, which in turn will activate the intestinal fibroblast, the plasma, the neutrophils, and the macrophages, which have their own function. But if we block this, there is less inflammation. Uveitis also, if you look at TH1 and TH17 cells, which get activated when TNF alphas is being released, they go and migrate and infiltrate the uvea and cause inflammation. Block this and the uveitis is being taken care of. And similarly, there are lots of papers on, basically the mechanism is mostly, the same mechanism is being employed, whether it is JIA or hidradenitis, Behçet's, pyoderma, Takayasu arthritis. So TNF alpha does play a vital role in disease pathogenesis. So let's block it like those experiments. And how do we block it? We have TNF inhibitors for that. And this is a beautiful figure. I think it's from Hoshbach probably. The infliximab, this has a murine sequence. Adalimumab is completely human. Golimumab, certolizumab has a human sequence with murine hypervariable region. I'll show you a different figure in the next slide. Yeah. So this is, this is how the IgG looks like, just for revision. They have a light chain, they have a heavy chain, and there are two hinge regions. So what are these TNF alpha blockers? They are nothing but, most of them are antibodies. They are monoclonal antibodies. Infliximab is a chimeric monoclonal antibody, which has been developed from murine myeloma cell line. If you look at the VH and the VL region, they are derived from mice. Similarly, if you look at golimumab, the golimumab is nothing but human IgG, which has been expressed by the mice, which have been immunized with TNF, transgenic mice. So this is producing human IgG, golimumab. Look at etanercept. Etanercept is nothing but two TNF receptor 2 receptors, which have been clubbed, combined with the Fc portion of IgG. If you look at these 6 molecules, except for certolizumab, all of them have an Fc portion. Now, this is very important. Why? Because some of the mechanisms, some of the methods by which these drugs act are mediated by the Fc portion. But if you look at certolizumab, they only have the FAB, and only one hinge region. Just look at it here. There is only one hinge region. There is a FAB region. This is the FAB here. This is called as FAB. And they have pegylated, which increases the half-life of the certolizumab, and hence once a month dosing. Sometimes we do use once in 2 weeks, but once a month dosing with certolizumab. So because of these subtle differences, there are differences in the way they act, in the way they bound to the membrane TNF, the soluble TNF. And I have the next slide, which will sum it up. So infliximab, adalimumab, golimumab, certolizumab, they all act on only TNF. They act on the only soluble and transmembrane receptors, whereas etanercept also acts on lymphotoxin alpha. There is one very important difference between infliximab, adalimumab, golimumab, when compared to certolizumab, is FC-mediated complement-dependent cytolysis and ADCC, not seen with certolizumab. There are some papers which talk about etanercept does act through FC portion, but then there is also a question mark on the mechanism of the FC mediating this ADCC and complement-dependent cytolysis. But this is not so, straightforward that if you have an FC portion, these mechanisms will be mediated in all the diseases or in all the cell lines. Interestingly, in RA, the effect of infliximab has been shown. Adalimumab has somehow not been able to show increased apoptosis of these activated immune cells, but only in Crohn's disease, not in rheumatoid arthritis. We really don't know why. What is the difference? Why that in a particular disease, one molecule is able to mediate its effect through apoptosis, but not in the other disease. And this does not only is limited to the disease, but also to the cell lines. For example, in Crohn's disease, in RA, it is mainly the synovial macrophages which are undergoing apoptosis, whereas in Crohn's disease, it is the lymphocytes. Etanercept, there is some data on synovial macrophages, but no impact on in Crohn's disease. Just a bit of mechanistic angle. Why do we add methotrexate is because of the impact of this drug on the pharmacokinetics. It decreases the clearance of these drugs as dose as low as 7.5 mg. For infliximab, it decreases the anti-chimeric antibodies. However, on etanercept, there is no impact on pharmacokinetics. Future lies here. Just block this pathway. Do not affect this pathway. So how we can do that? Either something downstream, or we make a protein molecule which is very specific for TNF receptor 1. So there are various next generation selective inhibitors in pipeline, something called as atrosab, which is nothing but full length IgG, which acts against a specific epitope present only on TNF receptor 1. Similarly, there is MDS 5541, which is acting on, again, TNF receptor 1, very specific. CROSS is a trivalent nanobody, which is consisting of two distinct domains. One binds with TNF receptor 1, the other is an anti-albumin domain. And then there are TNF muteins. Again, I don't know when they will be available, but the theoretical aspect, having known the pathogenesis, having known the mechanisms of various receptors, I think it stands probably good chance that these TNF receptor selective proteins might improve might decrease the side effects, might not disturb the homeostasis which is achieved with TNF receptor 2. Still, there are lots of unsolved queries, like I mentioned, impact on apoptosis. Etanercept is not useful in IPD. We don't know why. They say probably they have no impact on lamina propria mononuclear cells, or they do not cause apoptosis of peripheral T cells in this disease. So still, there is a lot more to learn, lot more to decipher. But since 1975, we have, I think, come a long way. We have understood how the TNF family looks like, with a major villain being TNF alpha. Not villain exactly, but yes, has an important pathogenic as well as homeostatic role. And we have seen how important it is in lots of autoimmune diseases. The future probably would be, on a more specific inhibition. Thank you. This is just a summary slide, how you just block TNF wherever you see, jahan bhi dikhe usko pakdo, maro, and you might be able to decrease the inflammatory T cell milieu, improve the breakdowns, improve the erosions, improve the accelerated atherosclerosis, osteopenia, and so on and so forth. Thank you.
Thank you, Dr. Avinash. It was an excellent lecture, especially looking into the various aspects of TNF. Starting from the history to the future was the best component of that. I think we will open for a few questions, maybe 2, 3, so that
if people have survived, they can ask questions.
yeah. Looks. Yeah. one of the critical point that I always wonder is we always think that the blockade of TNF is single line effect. Is that all it is so, or is it the multiplicity or more than what we expect happens?
Actually, yeah, that's true, sir. Very important point that you brought out. It's not as simple, because even looking at those complicated downstream pathways, we really don't know when they make a switch. When those complex 1 and 2 will make a switch and will start activating C-flip, which inhibits caspases. That is something which is very not clear. They have understood that how they do it, but when they are making a switch, how they make a switch, is it increased concentration, decreased concentration? Is it the difference in the ratios of TNF receptor 1 to 2? Is something which is, I think, still probably not clear.
There are few observations actually where they say that the patient has pre-exposure to steroids or pre-exposure to some of the immunosuppressants. The effectiveness of the TNF blockade may not be as much as you see in a steroid naive or a immunosuppressive naive. How much you expect from the theoretical background it could be true?
I think, sir, from the experiments where people have shown that those who have a higher baseline TNF alpha, they do better. So extrapolating from there, I don't know, either is it because the baseline TNF alphas in these subset of patients who are already on immunosuppression is low, the expression of the receptors is low. Is it because of that? Or there is some other reason? To be honest, I'm not very sure. I think if you can, if there is anything more to it.
It's more or less the same, basically because of the alteration what the steroid or any immunosuppressants would have done is one of the same mechanism through which probably these TNF receptors or TNF blockades may not be as effective as you expect in that.
Right. Okay.
I think there is one question from Dr. Vijay Rao.
Yeah.
It's not only to Avinash, of course, Avinash can answer that first to the whole panel. So now that we have so many choices, especially in rheumatoid, considering that, what inflammatory milieu you took us through. So how would you place your choice of drugs? I mean, would you use B-cell blocker first or TNF alpha later? And first, number one. Number two, what's your thought about using JAK inhibition in combination with anti-TNF?
I'll answer the second one. That's a very dreadful question. I would probably not do it. I'll allow someone else to do it and see if there are no side effects. Then I'll try using it because, these are very two potent molecules. And I don't know if you are inhibiting the most dreadful thing is infection, which I think we all know. If you are inhibiting two important cytokines there. Regarding the first question, sir, I think probably the theory and taking it to the bedside has not always been the same. I always used to, crack this joke, when we used to have these seminars. We used to have seminars on T cells, B cells, then T follicular helper cells, dendritic cells, these cytokines. And at the end of every seminar, I was like, yahi hai. Isko pakad lenge, to disease theek ho jayega. Each and every cell used to feel like this is the culprit, this is the culprit. Same thing with all the cytokines. So I really can't say, that this cytokine, if we abrogate or if we attack this one, would turn out to be better. Because when we see the results, most of them, the take-home message is those who are resistant to conventional disease-modifying drugs, 60 to 70% of them will show response to whatever biologic that you use. Once they are refractory to the second line, the percentage drops down to 50 to 60. So I really don't see if it has really translated into, an order in which we can pick up this followed by this. So I only do it by the contraindications. If I cannot, because of these reasons, I cannot use this and money, I take a call. I am really not too much delved.
Just to add, actually, see, there are 2 or 3 papers which has been published from the gastroenterology group about the combination of tofacitinib and TNF. They have already ventured that. And of course, they find a good response for both TNF resistance as well as tofacitinib resistance when you combine that. Infection rate was slightly higher than what it had been used isolation, but it could really prevent the colectomy, which is one of the dreaded thing which most of the gastroenterologists are worried with the inflammatory bowel disease. I mean, when I was reviewing for writing my book on tofacitinib, I went through these two published articles. They say you can use it, but with a due caution. As you said, we are worried when you are trying to combine two drugs. Regarding the first question, that I think probably that's one of the work which I'm doing it from last 5-6 years without much of the results, because most of the studies where they're trying to work on profiling the cytokines, profiling the B cell, T cells, have not really resulted in such a good predictable model with reference to which is the best choice, whether to choose TNF block or a B cell block or a combinations. I mean, I think probably, hopefully next 4 or 5 years, we should have an answer, whether we should have, we should pick one of them, or should we go on cyclical manner, like use TNF followed by B cell, or use B cell followed by TNF. I mean, some sort of these answers may come. And as he presented in the last few slides, probably we may go more precise in what we are now working with. We are working with a very grossly blocking all the TNF. From that, we are now moving to block the one component or one aspect of the TNF activities. Probably that may improve upon the way we look at the biologics.
Yes, sir.
Difficult is it? How easy or difficult is it to measure TNF in the synovial fluid or blood? Can it be used as a biomarker?
So, sir, yes, there are papers where people particularly have, while trying to understand how it acts, they have used it. But unfortunately, most of the reviews have told that this has not really helped in deciding. That is number one, should we use it in these patients? Because it has not been possible to show that those always who have a higher baseline TNF alpha are definitely going to respond better vis-a-vis. So even in that experiment which I showed, where they had used that Paulius, some 6 variable criteria, though it was significant, but the percentage of improvement or the decline was not so significant that it could be brought into clinical practice, where we just check TNF alpha before and after. And I think there is a complex multi-bead assays and RAs which have been used in research, where they combine 10 or 12 of these molecules and take a call. But again, that has not really helped in really deciding. I don't know, sir, if...
Yeah, I mean, just only there is one available tool on the online, what is called as TNF response predictor. I think I'll share that particular tool. They charge somewhere around $80 for the test to be done. It's available in US. It's approved by the FDA for that particular test being done. Where you can ask them to do, they do some cytokine profiling, and they say whether patient can respond to TNF or not. That's all. The answer only comes is, will he do well with it or not? Not beyond that. So it doesn't suggest you what to use. It can only tell you that whether it works or doesn't work. I'll share that tool, but it's not available in India. But I was just trying to look into that. They're patent protected. Can I copy that? We can't copy that because it's patent protected.
And the same thing happened in those set of experiments where they took out the synovium, and they could not really show the same effect on the lymphocytes. You know, the homing of lymphocytes should have decreased in the synovium. In the periphery, it should have increased, but they were not able to show in all subset of patients. So we really don't know how we are going to.
Chandrasekhar, I have one question.
Yes, sir.
This is to Avinash, Ved, Ramesh, everybody. See,
Yes,
this is my 45th year of rheumatology practice. I have used methotrexate very extensively. And in spite of JAK inhibitors, biologics, all new drugs, everything, I never had the satisfaction what I had from using high-dose methotrexate from day one, from the beginning. And most of the people were very happy till these new drugs came in last 2 decades or 1 decade or whatever it is coming there. I don't know whether I'm biased or I belong to old school. I still am very happy using methotrexate as my first choice in majority of my patients. Am I wrong?
No, it's the same here, sir. Old school. Methotrexate, all 100
agree.
patients.
Methotrexate is the right one first to start with. Subsequently, failing which, then you can jump the gyms.
Is the disease becoming more refractory, Chandrasekhar? now?
No, actually, it's more than refractory. I think I presented one of my presentations 7 years
I
ago.
remember that, yes.
It is basically because we have switched the target. We have moved the target from patient's pain relief to a treat to target, where we are looking at a DAS score to be below 2.6 and the inflammatory parameters to low. Basically, because we have changed the goalpost. Because of that, our aggressiveness on the treatment has changed. Earlier, we were happy if patient comes back and say that I am not taking painkiller, my pain is gone. But now we are not happy with it. We want the parameters to come down. We want the DAS score to be below 2.6. That's the reason probably we are using and trying to use much other drugs.
Thank you.
So
Avinash, sorry for, can you hear me? I was just
Yes,
testing
yes.
my system.
Yes, sir. Yes.
Yes. So सिर्फ
Why-
टेस्ट ही
why-
करना, मुझे मत टेस्ट करना.
No. Why it did not work in septic shock?
Sir, don't know. The theory was right, the pathogenesis was right, but it didn't work very much. Like, I don't know why TNF really didn't work in.
Sir, two reasons why it's been said is that the TNF introduction was late in the course of the sepsis. Yeah, in the one, there is a point in sepsis, what we call as rolling down point. If it goes to that roll down point, it's like avalanche. You can't stop it. It just has to touch base and leave the impact and then repair whatever it can happen. So that avalanche slowdown point is somewhere where we are unable to still map it.
Something similar to cytokine storm.
I think if
something similar to cytokine storm, right?
Yes,
in COVID.
It's similar.
The right time you have to hit, and otherwise
it just rolls down. It just rolls down.
Where even Miney and Mark said that they don't know why it didn't work.
Yes.
I think now we have gone 15 minutes ahead of schedule. I think thanks for an interesting discussion. Now we move on to the second speaker, Dr. Vijay K. Rao. Dr. Vijay K. Rao is a consultant rheumatologist and proprietor at Divisha Arthritis and Medical Center. He is previously consultant rheumatologist at Manipal Hospital, Bangalore. He has several publications. He is an RCP examiner for MRCP, PACE exams at Bangalore. Past, he was assistant editor for Indian Journal of Rheumatology. Over to you, Dr. Vijay.
Thank you very much, sir. You can see my screen.
Yes, sir.
Yes.
Yes. Okay. So what I realized when I was doing literature search for this was my topic was pharmacokinetics and pharmacodynamics, and there's really very less papers because these are all dating back to 1990s or 2000s. And I'd really had to fish a lot in terms of using, which I should search for. I finally ended up going for NIH publication, which they had released at the launch of these molecules. Each of these molecules, NIH had released a publication of source data. So I had to go back to that. And that was the only thing. I really won't be showing you much pictures as Avinash did, because this is all hard factual data. There's no, clinical data here as well. So it's a bit boring. You have to bear with me. So we learned that it's a pleiotropic cytokine, which has a major role in inflammatory responses. So anti-TNF blockers are designed to block the biological function of TNF and has been in use for therapy of autoimmune rheumatic inflammatory diseases. So I shall be, enumerating the individuals, pharmacokinetics and dynamics of each. So infliximab, etanercept, adalimumab, golimumab, and certolizumab. I'm not going touching upon certolizumab for the simple fact that none of us have used it here in India. Although I did briefly use it in the UK from 2009 to 2013. I myself did a choice of biologic survey in Birmingham and found that the most preferred biologic was adalimumab, which is Humira, followed by etanercept, then certolizumab. infliximab had almost phased out by the time I was finishing training in 2012 in the UK. The least preferred was golimumab. And interesting, it is actually published data. It says that the reason for physician choice for adalimumab was the pharma company were more seen to all the prescribing doctors. That was one of the reasons we had found out, apart from scientific and efficacy and all that. So, and other companies were not visible at all. And these were very honest. In fact, people were, as an anonymous data, they came up. Also, the fact that adalimumab has widespread indications, and so it's the most preferred biologic. So it is used for the treatment of rheumatoid arthritis, inflammatory bowel disease, psoriatic arthritis, GIA, and spondyloarthritis. So we've been through this. So the T cell activation of macrophage and release of TNF alpha, which downstream NF kappa beta and chondrocyte activation, release of MMPs, joint inflammation and distraction. And this is where the TNF blockers play a role. Apart from the other blockers which are used to treat autoimmune inflammatory diseases. Now, Dr. Avinash showed this slide, but this made me think how far we have come. So in 30s, we came up with non-steroidal anti-inflammatory drugs and gold salts. 50s was steroids and hydroxychloroquine. And 60s was sulfasalazine. Then followed by D-penicillamine, which I used to see a few prescriptions in the UK when I was just started training in 2008. Of course, phased out. And then followed by cyclosporin in 80s, and then injectable golds. This again phased out in 2008 or 9. Then followed by leflunomide methotrexate, the big game changer in 80s, late 80s. And the real one was, leflunomide with etanercept came in 1998, and infliximab 99. And then, of course, humanized adalimumab 2002. And the latest anti-TNF, was 2009 golimumab after certolizumab in 2008. Downstream following which several things have come. But before we came to the anti-TNF, we have quite a few of drugs which we have used and still using, as Dr. Mahendranath sir said, the most preferred being the methotrexate. So if you look at a snapshot summary of currently available anti-TNF, their mechanism of action on approved indications. So infliximab widely used for seropositive RAs, seronegative arthritis, including psoriatic arthritis, spondyloarthritis, inflammatory bowel disease. Same thing with adalimumab, but etanercept not so much popular with respect to inflammatory bowel disease or uveitis, but certainly a big hit in JIA or kids. Downstream, they were not so popular, although it got approved for the similar indications. So if you look at the molecule as such, in a comparative slide, so infliximab is a chimeric or mouse-derived monoclonal antibody, and this is the murine variable region where it actually attaches to the TNF molecule. And it's got a constant region of immunoglobulin. Then etanercept is a fusion protein of two TNF receptor extracellular domains and the Fc region of IgG1. Whereas adalimumab and golimumab are fully humanized monoclonal antibodies with a Fab region, which is fragment crystallizable region, and fragment antigen binding or the stabilized Fc region of the IgG1. Certolizumab is a certainly design wonder because they've got a humanized fragment with no Fc region. So it is a slightly different molecule with no Fc region in this, but a pegylated fraction. And for that reason, probably initially Anisur Rahman and colleagues and Caroline Gordon, when we were doing the pregnancy rheumatology clinic in Birmingham, thought that it is safe in pregnancy. This was, of course, initially before the latest BSR guidelines came. And they thought that they hardly cross the placenta because of the pegylated fraction, and it hardly goes to the baby. And initially it was popular before even the BSR guidelines came for pregnancy usage in anti-TNF usage in pregnancy. So if you look at the infliximab, it's the only TNF blocker which we have been giving intravenously since 1999. Its dose, as we all know, is adjusted as per weight. It's a full-length bivalent IgG monoclonal antibody. So it's composed of 2 heavy and 2 light polypeptide chains, each of which contain 3 complementarity determining regions, that is CDRs, in the VHLVN domains. And it's got 2 antigen binding. These are the 2 antigen binding Fab arms linked to a glycosylated FC region, which is the stabilized region via a hinge. So it's generally composed, this region is composed of, that is the antigen binding site on the Fab portion is composed of composed of amino acids from the 6 CDR regions in the HL chain pattern or pair. And it is actually the VH and the VL part, this part, which is the murine derived protein. It's about 25% of that is mouse derived. And that's where the immunogenicity kicks in, where our own immune system produces antibodies against this because it's not humanized. And the 75% of that is in actually the CH1 and the FC constant regions, that is in this part. So it has the association and dissociation constant as mentioned here. I'm not quite sure how that translates to clinical as such, although I looked for it. So it's a chimeric human anti-TNF monoclonal antibody composed of murine variable and human IgG constant region. It binds both to monomer and trimer forms of soluble TNF alpha. It forms stable complexes with the soluble TNF alpha. And each infliximab molecule is able to bind 2 TNF molecules at a time. So if you look at the specifics of pharmacological characteristics, it has a half-life of 8 to 10 days. Its target binding site is TNF. As I just enumerated, it's a chimeric human murine anti-TNF monoclonal antibody. As Dr. Avinash showed, it works through complement-mediated cell lysis, antibody-mediated cell lysis and toxicity. Its preferred dose is 0, 2 weekly, 6 weekly, that is the loading dose, at a dose of 3 to 10 milligram. Although I'm surprised if somebody uses 10 milligram, I've always been told 5 milligram max. These days, and I've been using it, avoiding loading dose and using 4 weekly, and it's not causing any major problems. But the prescribed ones is 0 to 6, and then it's 8 weekly after that. So the association and dissociation constants have been enumerated here. I'll come to the further descriptions later. If you look at the indications of infliximab, so it's been widely used for rheumatoid arthritis. We'll come to the clinical trials part, I'm sure, in the later talks. Ankylosing spondylitis, including uveitis part. Psoriatic arthritis, including the uveitis. Then adult Crohn, it's popular in inflammatory bowel disease, Crohn's and ulcerative colitis. Much less popular for GIA as such. In fact, hardly, it's not even licensed for usage. Etanercept is a dimeric human TNF receptor fusion protein, which is made up of 2 extracellular domains, these ones. linked by a constant FC IgG1, this part, which is the stable part. So this binds to the TNF, this part binds to the TNF, and this stabilizes the molecule. Okay. It consists of 934 amino acids and has an approximate molecular weight of 150 kilodaltons. So the dimeric structure, this dimeric structure is the key part of etanercept that enhances its binding affinity and provides substantial greater competitive inhibition of TNF alpha than the usual monomeric soluble receptors. That is, what we inherently have. And use of an IgG-Fc region as a fusion element ensures that it has a longer serum half-life compared to the inherent TNF alpha receptors, what we are born with. It competitively inhibits both TNF alpha and TNF beta. What Dr. Avinash just showed, that lymphotoxin, this is the only anti-TNF molecule which blocks TNF beta to cell surface TNF receptors, inhibiting the TNF to block our endogenic or inherent TNF receptors and rendering them biologically inactive. It also indirectly has different biological responses, such as it blocks the adhesion molecules, production of interleukin-6 and MMPs, as well as IL-1. So T cell responses to microbial antigens as well as to collagen is not altered. The peak concentration is reached approximately about 51 hours with a maximum concentration of 1.46 microgram per milliliter. Elimination half-life is around 68 hours. And standard dosing is 50 milligram subcutaneous given once weekly or even 25 milligram twice weekly. There's no dose adjustment required for renal or hepatic impairment. And if you look at the indications, so popular among JIA and rheumatoid arthritis, psoriatic arthritis, plaque psoriasis, and spondyloarthritis. These are the approved indications for the use of etanercept. Adalimumab is a full-length bivalent monoclonal IgG1 antibody with a molecular weight of 150 kilodaltons. It targets both membrane-bound and soluble TNF alpha. It's derived from the Chinese hamster ovarian cell line as shown by Dr. Avinash in his pictures and is developed with a phase display technique. It consists of completely human IgG1 kappa sequences and indistinguishable from actual human IgG. It's almost near match. And it binds to 2 soluble TNF alpha molecules and has the potency to bind to even more, forming something as multimeric complexes, thus preventing soluble TNF alpha binding to the natural TNF alpha receptors. So apart from the usual competitive inhibition, it also binds to membrane-bound TNF alpha molecules, apart from soluble, with potential cross-linking and reverse intracellular signaling. I'll come to the picture shortly showing that. So direct neutralization of soluble and membrane-bound TNF alpha, apoptosis and cytokine suppression through reverse membrane-bound signaling, and ADCC or antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity is all the mechanisms of action through which this molecule helps in blocking TNF alpha. If you look at the diagram, this is the binding site of TNF molecule. This is the fat portion. So this is the variable region of VH and VL chains. And this is the constant stabilizing part of the human IgG. So this picture shows us the mechanism of actions. This is the trimer or multimer complexes. It binds to the soluble TNF alpha, thereby preventing the TNF alpha to attach the inborn receptors and stopping the down-mediated effects. It induces antibody-dependent cell-mediated cytotoxicity via binding to the Fc gamma receptors on the effector cells. It directly activates the complement cascade and induces what we call as complement-dependent cytotoxicity. And downstream effects of membrane-bound TNF-alpha, reverse cytokine signaling, cytokine suppression, and apoptosis. And thereby, the TNF molecule is avoided in binding to the TNF receptors, both membrane and soluble. So its absorption is low with a maximum serum concentration of 4.7 micrograms per liter. It takes about 6 to 7 days to reach that. And that's where we start seeing the clinical effects as well. So average absolute bioavailability is around 65%. It's never nearing 100%. So with the 40 milligrams subcutaneous injection, the mean steady state was reached at 5 microgram per ml. However, look at this. If you combine methotrexate, that's what the NIH data says, that the serum concentration is higher. It reaches up to 9 microgram per ml. So always it's advisable to use methotrexate with anti-TNF molecules unless contraindicated. Also, methotrexate reduces adalimumab clearance by about 30% with single dose and up to 45% to 50% with multiple doses. And with respect to the antigenicity or the immunogenicity or the anti-adalimumab antibody studies, patients receiving adalimumab with or without methotrexate, especially methotrexate and other DMARDs, so are associated with higher serum adalimumab concentration, or those who use it as a monotherapy associated with lower serum adalimumab concentration with poorer clinical response. And this is well out in the domain in all published data. If you look at the indications, so maximum indications, approved indications are with adalimumab, and that is why it is so popular. So 2002 was the first with rheumatoid arthritis, followed by 2005 with psoriatic arthritis, then ankylosing spondylitis, Crohn's disease, plaque psoriasis, GIA, moderate to severe ulcerative colitis and IBD, and even hidradenitis suppurativa. It's an approved indication which the dermatologists have been using. Lastly, golimumab. It's a full-sized antibody with the molecular mass of approximately 150 kilodaltons. And it was originally isolated from a hybridoma clone from a transgenic mice that had been immunized with human TNF-alpha. And the golimumab secreting clone was selected after being assayed for human light and heavy chains for TNF-alpha binding. The commercial product is produced in a recombinant cell line cultured by continuous perfusion. So human TNF-alpha molecule, this golimumab, binds to both soluble and transmembrane bioactive forms, preventing TNF-alpha to its receptor, thereby preventing, it's similar like adalimumab, all these mechanism of actions. It has a variable Fab region and a constant Fc region, and this is where it binds to the TNF molecule. If you look at the pharmacokinetics and dynamics, so its binding affinity for the target is almost same as adalimumab, and it's heat stable, and it has dissociates as you heat it up. And liquid formulations are stable at 100 milligram per ml, but the marketed product is actually 0.5 ml dose, which is 50 milligram per 0.5 ml dose. So it can reach a maximum serum concentration of 2 to 6 days. We see normally in clinically about 7 days, it starts seeing effect. But it's a monthly dose we give, and there's an approximate bioavailability of around 50%. With healthy volunteers, that is without the disease, the maximum concentration reach was around 3 microgram per ml. So if you look at the specifics of the golimumab injection, so it is colorless to light yellow, and the company product says that if the color is altered, do not use it. And half-life is around 14 days. Bioavailability is around golimumab around 50%. The peak plasma concentration is around 3.2, reaching in 2 to 6 days. So normally it says do not heat, just sit out at room temperature for about 30 minutes. And usual injection sites for etanercept, adalimumab, or golimumab is front of thighs, which is recommended, or lower abdomen, except for a 2-inch area right around the navel. And do not administer if there is psoriatic patch there on that, or if it is tender, bruised, or any local infection. And it's recommended to store all these products at 2 to 8 degrees, at which it's heat stabilized. But do not freeze any of these. And it says that do not open from the original carton to protect it from denaturing or dissociation from sunlight whenever the fridge is opened or cold storage is opened. If you look at the indications, the approved indications are quite less, and hence probably it is less popular as a biologic. It's phenomenally expensive in India, hence not taken up very well. Except if it is funded by government agencies. So it's approved for rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis, but none for IBD, none for uveitis, none for JIA, and hence not so widely popular as adalimumab. Thank you.
Thank you, Dr. Vijay, for taking us through all the preparations that are available, and also dwelling on the pharmacokinetics, pharmacodynamics, and also how to use and approximate dosages, how we schedule it. I think with this brief note, I will open up for any questions.
What is your view on spacing out biologics?
I mean, that's something which we are forced to do, and also does work, actually. See, when you said in your experience, you're using infliximab.
I'm avoiding loading dose.
First, the loading dose, second, you space it after a week, and then followed by 1 month or 2 months. What I do normally is I don't go for such a frequency. I think probably Dr. Ved will share his experience. He's the one who has designed and coined about that spacings, where we could use lesser dose and we could space it more. Probably in his lecture, he will be dealing.
I will because they have my video is probably it is still not enabled. I'll request but yes, we will discuss, and that is. I feel that time in 2002 was a big job, because everybody was criticizing me. You are unscientific and all those. It happens with all the clinicians.
Yes.
And etanercept 25 mg has never worked with my patients, so I've stopped using it.
It does work. I have one patient who is on that etanercept from past 25, from past 15 years. Even if he misses one injection, he has a problem. And sometimes he spaces it himself. Instead of taking once a week, he takes 2 weeks, 3 weeks, like that. So it has to be highly individualized and characteristic. The reason I personally feel is because you have to look at the variability of the TNF in the normal population. The normal TNF distribution is very wide. So if the TNF secretion itself is so wide, I anticipate to have a wider range of its responsiveness technically. So one may respond to as low as a 10, and one may not respond to as high as 100 micrograms of mg of etanercept. That variability is theoretically expected, but it's very difficult to do any such clinical trials based on these facts. It's anyway, dose ranging trials, you have a specific method in which you have to run through. So I mean that's where is the trouble is. So I think it's maybe very difficult to get that particular things. Hopefully personalizing the medicine may answer that.
Now my video, just can somebody request the I think my video is they have enabled, so this is start my video. Yeah, now it's now, and I think it's done it.
Yes.
I think today all technical issues are.
Vijay, some part
Yes,
of my talk will cover these aspects. I'll be showing evidence for what you asked.
All right, that's great. Okay, fine. I think then Dr. Mahendranath, any questions?
No questions. No.
Right. Okay. So I think that, then I think we will move on to the next topic. Dr. Lieutenant General Professor Ved Chaturvedi. He was my senior when I was doing my DM clinical immunology and rheumatology at SGPJ. Of course, he has a long outstanding career at Army. And he was a professor in HOD in Army RNR Hospital. He did his DM, Clinical Immunology and Rheumatology, in 1995 from SGPJ. Subsequently, he had a lot of awards and orations. Most critical of them is PVSM in 2015 and President Honorary Physician 2015. And highest National Rheumatology Award conferred in IRA, that is Lifetime Achievement Award of MN Passe Award in 2018. Of late, in 2019, he has Atal Swasthya Bhushan Award. Over to you.
Thank you. Now let me, you have spoken, let me try whether the slides are, he's sharing the slide?
He will share the slide. Anand, to start the slide.
Okay. Or I can also do it if he wants. Should I share the screen?
Yes, sir. As you told, you can only share, sir.
Achha, okay. Let me do it. Let me do it. Just a minute.
Yeah, you are in.
Yeah, let me
Go to full screen.
Yeah, full screen. From where? That is the
bottom, lower bottom, right side.
Yeah. I got the thing. Yeah, is it visible?
You're right. You're in. Please go ahead.
I could not hear these two lectures because of the technical issues. That is the whole thing. So I was really, I was so scared. Now it will run like this or it will run like this?
Yeah, okay. It's moving.
It's moving. So currently I'm working in Gangaram Hospital after leaving this hospital, my army hospital. So just to people who now, so this is the yeah. So my brief is to speak about different stages of the disease. I always feel there are a lot of, you always keep seeing the guidelines, but not much has been written about the early disease and late disease and how to go about it. So, you know, both this is father and son, actually, both from Dubai, and both take anti-TNF and both respond differently. So there are many things to share about this. So my exact brief is to choice of prescription evidence based and anti-TNF in ankylosing spondylitis and psoriatic in IBD. Now, we all know about this, but why I'm purposely showing it basically about the stages of the diseases, which probably people have the role of anti-TNF has not very well described in the very severe disease or a late disease or a very early disease. Fortunately, when I was in Army Hospital, because of referral issues, even early cases in 99 and 2000, most of the cases actually were non-radiographic, which we call it now non-radiographic, or I call it always early disease. So goal of treatment is, we all know about this, about basically what we could achieve probably is the quality of life we really don't know about the structural damage, and we have. Is it audible? Audible? No issue. So my brief is not to talk about the management.
इनका तो reimburse होता है ना?
I think somebody.
Procedure charges.
Avinash, you have to mute.
I think you have to mute somebody. I can. Yeah, it is disturbing me. So my job is not to speak about the management of ankylosing spondylitis. My job is to speak the role of biologics, anti-TNF, especially. So we all know about all this, how it is used, but actually biologics, especially anti-TNF, what we could achieve actually, all of us are using it. We were discussing, we have definitely, we could, in ankylosing spondylitis, we could control the pain. The pain was a very, very significant thing. So we could achieve with anti-TNF. Definitely the improved quality of life also. Control of inflammation also, because ESR, CRP, and whatever parameters you use. We really don't know about the structural damage. A lot of papers are coming on structural damage. Basically, how the inflammation develop and can ankylosis be retarded or prevented? That is a question a lot of people ask now. So basically, this is an early disease in the spine, and that is how it goes. So we all know about this cartoon we have seen. So basically, in the beginning, there is this is a proposed sequence. If you see, there's an inflammation, and then there is some erosive damage repair, and then there is a new bone formation. So you have to choose how much early you can use. And this is a very old cartoon which was published in rheumatology. That on the same line, that early inflammatory lesion, and which is leading to mature and bone growth, and which previous speakers were talking about BMPs and all, and syndrome fight. So most of the, unfortunately, if you see the earlier studies, it is all on the late, because late cases, that because of the problem of the regulators, because they were used anti-TNF initially, they were used when they're already syndrome fight, or there is a bilateral sacroiliitis radiographic. In fact, I was lucky that I could use in early cases, because probably that time guidelines had not come, and this was year 2002. So basically, if you ask me about the beside BAS-DI and ASDAS, the radiographic damage in the spine is also very, very important, and it's an important outcomes we must measure. And a lot of people say that everybody does not progress. If you really ask me, that most of the people progress. If you see this also, this is a non-radiographic, means it is only seen in MRI, non-radiographic. So about 12% in 2 years, they progress to this. And that is how, if you see this cartoon also, that most of the people, they over a period of time, they progress to radiographic. So this is a non-radiographic, this is radiographic. But over a period of time, say in 12 years time, almost, as I said, roughly about 12% in 2 years. So if you have 100 patients, they will progress in this about 12% in 2 years. So very, very important. This is a very important slide, which was published again in Rheumatology in 2015. This was a longitudinal change in syndrome fights volume. We see syndrome fight in a plain X-ray, but if you see a computerized CT scan, especially the anterior syndrome fight, this is anterior, this is posterior. If you see this posterior syndrome fight in a 1 year time, which was hardly about roughly 27, it became 123. So probably they progress very fast. These patients are young. Fortunately, we see this is an original photograph from the Army Hospital. 90% patients were in this age group when they were coming, and they were early disease. And over a period of time, we realized, because we have to, that time it was very difficult to present to the administrator. It's an old slide in 81, that why we are using such a costly drug. That time it's very costly. So we have to see this, there's a survival curve. They do die early. These patients do die early. So they requires a more effective therapy than what traditional therapy there. Of course, this we know how it happened with the Jurgen Brown. That is the biopsy of SI joint, and rest is the history, because probably the Dr. Manny and other people, they did not agree that it will work in ankylosing spondylitis. This drug was already available in rheumatoid arthritis, and I was using since 99 for rheumatoid arthritis. But when this paper came, it was published in Lancet. Then came the anti-TNF drug. And believe me, this Lancet paper in 2002, when it came, it just had 27 patients. And around same time in 2002 to 2004, I already had drug, and I already had ankylosing spondylitis patients, because Army 1.2 million. That time I was in uniform. So Army is basically male dominated. So 1.2 million males. So I had about 10,000 patients of ankylosing spondylitis. And that in very first time, I in just 2 years, I collected about 127 patients on biologics. And we presented our work. And as we were discussing that time, the initial the problem was tuberculosis, the fear of tuberculosis, especially in Asia, because Dr. Manny said probably you should use very cautiously, and maybe it is not for Asia because there are a lot of tuberculosis. And this was I studied that initial papers of Dr. Manny, and I told him that you have more tuberculosis, what is happening in the early. And what is happening early is the loading dose, which Dr. Rao was telling, 0, 6 and all. So if you don't use, probably you'll not have tuberculosis. And we presented our data to DBT. Unfortunately, didn't publish it. We have Armed Forces Research Committee, which is with the DBT and ICMR. So I presented this work that if you don't use loading dose, you will not have tuberculosis. And this was our hypothesis. And I said, you don't use the 5 milligram as you were using for rheumatoid arthritis. Use 3 milligram instead of 5 milligram. You will not have tuberculosis. And this was our first patient in 2002. So 99 we started using biologics. In 2002, this was our first patient on ankylosing spondylitis, which came for hip replacement. And this was the work which we presented in APLAR in 2004. It was an oral presentation that no case of tuberculosis. So we were very sure that we are doing a correct job, that we are not giving loading dose. That time only infliximab was available. So we call it low dose infliximab. Why we call it low dose? Because we were using not 5 milligram, 3 milligram. We were not using the loading dose. So without loading dose in ankylosing spondylitis, a single center study of efficacy and toxicity of more than 100. It was presented in Korea, and this was the early in 2004. So then from 99 onwards to 2007, roughly we have collected about 3,000 patients on infliximab on ankylosing spondylitis, and etanercept we were not using much. And I was just calculating that most of these patients out of 3,000, about out of 3,042, 42 cases were the only cases which were advanced. Otherwise, most of the people they were early disease, pre-radiographic, that is a non-radiographic. So that time it was called as early disease. I had an advantage that we had a good referral system from all over the country, whether east, west, north, south. The person will get an air ticket free. He will come to Army Hospital. He'll get a bed also free, and he'll get a medicine also free. So we could, and later on we did have few tuberculosis, few infusion reactions, herpes, skin abscess, rectal abscess, alopecia, had everything, whatever people have seen. So our innovation that time was a no loading dose and a low dose infliximab. And of course, later on, my colleagues also start using it, and they said basically on demand and infliximab before surgery, because we had a lot of, we require perfect fitness in Army. So a lot of people had come for hip replacement, and we had a very huge department of joint replacement. I'm talking about 23 years back. And that time, the joint replacement separate department was not existing in the country, except in army hospital. So we used to advise the surgeon that you give the anti-TNF before surgery, you will do a better job. So that is the, so early disease in 2004. And sorry, so early probably disease is that is a time when it is reversible immune dysregulation, and the disease burden is also low, and you can preserve the spinal mobility and functional status and prevent loss of work productivity and long-term complication. So if you really ask me, these are the few studies which was done later on, that effects of tumor necrosis factor inhibitors on newborn formation and ankylosing spondylitis. They also write if you treat early. Fortunately, a lot of people say your data is really too good. No, if you treat early, an earlier initiation of TNF therapy may slow down the radiographic progression of ankylosing spondylitis. This is the paper from Harun in the arthritis rheumatism. Same thing. So probably that time evidence was not there. Though Chandrasekhar has chosen the word evidence to the practical uses, I have said first practical, then evidence. So probably whatever I was doing, somebody put it in black and white that TNF inhibitors are most effective when started sufficiently early in the disease course and when treatment is sustained for a longer period of time. So we could do both, that we could start very sufficiently early. Most of the patients came in 6 months to 8 months to 1 year. So they were early cases. So, and we could, because the drug was free, we could use it for longer time. So results was good. Can radiographic damage or progression be prevented by tumor necrosis factor? That has to be answered. That not only the quality of life, not only the pain, not only even the inflammatory component in the MRI, but can radiographic damage or progression be prevented by TNF blockers? So this is another paper which says that yes, it can be done. TNF inhibitors treatment was associated with a 50% reduction in the odds of progression. So it does help. And this is the patient who were not on TNF inhibitors for greater part of their disease duration had increased rates of MSAS progression. MSAS is basically damage index. So that is the same thing is this is another paper that 8 years data. Look, initial data we had, but then we were waiting what happens in the long term. So this is the data which is published in Annals in 2014, that continuous long-term anti-TNF therapy does not lead to increase in the rate of newborn formation. So it does this. What guidelines says, that is also Dr. Chandrasekhar has given me this job. Now, this is the guidelines published by ACR in 2019, and this is the guidelines published ESAS and EULAR guidelines in 2022. So we will we'll discuss these guidelines in 22, and this is a ESAS and EULAR guidelines. Basically, what we do, actually speaking, if you really ask me, don't read even these guidelines. Whatever we are doing is absolutely that axial disease. Probably the only drug is the biologics. And what biologics, which we are discussing today, is anti-TNF. We are not discussing anti-IL-17. So that is what we are doing. For axial disease, we are convinced, and there's a data. That's why these recommendations are that for axial disease, for a regulatory purposes, they have divided into phase 1, phase 2. So phase 1, probably if you're diagnosed ankylosing spondylitis, and for 2 to 4 weeks, you can give NSAIDs. And if they respond, you can continue with the NSAIDs. Most of them, they will not respond. And then you switch to if it's an axial disease, you start anti-TNF. That is what we are doing, most of us. And that is but if somebody has a history of recurrent uveitis or active IBD, then monoclonal anti-TNF is preferred over the significant the other. So as it was discussed earlier, that I'll discuss when you have uveitis or IBD, then you can't use the monoclonal antibody infliximab. So you use the monoclonal antibody preferred than the etanercept. So that is so basically for axial disease, anti-TNF, that is the use. Just to complete, you can use anti-TNF also, but you can use the anti-IL-17 also. That is the, so for phase 3, suppose it doesn't work. So there can be a primary failure or there can be a secondary failure. If there is a primary failure, if it doesn't work, if the anti-TNF does not work, then you can switch to another biologic, another TNF you can work, or you can switch out to IL-17 or JAK inhibitors. That is how this is a phase 3. But actually what guidelines, what they say basically, that initially use NSAIDs, that is for regulatory purpose. You must realize you will hardly have a patient who will just respond to NSAIDs. Sulfasalazine used for peripheral SPA. We all know they respond beautifully. They respond to methotrexate also. But anti-TNF is used for axial disease. And when to use biologics, that you require definitely a rheumatologist to use it. That is very clear in guidelines, because that causes sometimes confusion. So rheumatologist diagnosis of axial SPA, and of course, elevated CRP, positive MRI, and radiographic ceruloplasmitis, and which we were discussing, that if you use NSAIDs in sufficient doses, at least 2 NSAIDs over 2 weeks. And for a peripheral, this thing, you can use the steroid and sulfasalazine, and high disease activity, whether you measure by BASDAI or ESDAS, and positive rheumatologist opinion. That's very, very important to continue with biologics or not to. That's very important. Suppose you're using a anti-TNF. You have used for 4 weeks and it is not working. And if you use for 8 weeks, so how long? So at least for 12 weeks. So 3 months before you call it a day that it doesn't work. So at least every patient will not respond. Normally, we all feel it's like magic bullet. The moment he takes first injection, he responds. Sometimes they don't. So there's a data which says that you have to use for 3 months before you call it that it's a failure. And what is the aim is this, that ESDAS improvement of this much and BASDAI. So this is which anti-TNF, if you really ask me, as well as the radiographic progression is concerned, all are same, whether you use A, B, C, this all are same. Which anti-TNF, we all know, practically this crowd at least know when to use etanercept. We don't use if somebody has uveitis or IBD. We are more using Adeli because of the availability. I use etanercept because of the least tuberculosis with this. Golimumab is costly. So we have our own issues that infliximab, somebody wants a quick result, somebody is appearing for exam, somebody is getting married, somebody is moving to US, then probably most rapidly working is infliximab. Of course, infliximab is the problem of tuberculosis with infliximab and adalimumab is much higher than etanercept. If safety is concerned, most of my 100+ patient of doctors, nobody has used. They use all etanercept because probably etanercept is safe. They're also using golimumab. Golimumab is also very, very safe. There hardly any case of tuberculosis has been reported. But we just saw one doctor from Bhopal who had a golimumab, but probably the initial diagnosis itself was wrong. Initial diagnosis was tubercular sacroiliitis, and golimumab flared so both etanercept is also safe. If the tuberculosis part is concerned, golimumab is also safe. Golimumab is costly. It is monthly, much easier. So it is every month. Etanercept is weekly, so that those issues are there. And usual situation in the real world, as I was discussing about uveitis, same as we can discuss whether somebody has a CRF, somebody has a tuberculosis, what to do. I had a patient from Bombay who had come, who had, after anti-TNF, he developed tuberculosis, and it was a COVID time. He came on wheelchair. Nobody was treating him. So there are a situation that you can use on different drugs so that we all can join together and use. These are the conditions which probably, what I was surprised from this, it was a news to me that even 98, no, in 98, it was approved for Crohn's disease. I didn't know about this. This probably, we all know about this, how the how it went around, and pediatricians also. EULAR recommendation for psoriasis. Now I'll come back to psoriasis. Another 2-3 slides. Psoriasis also has emerged very important in 2019. These were the recommendation. By and large, it is if you ask me about these recommendation or GRAPPA recommendations, different domains are there, whether you have a peripheral arthritis or have a axial, or you have enthesitis, or you have dactylitis, or you have only psoriasis or nail diseases, IBD or uveitis. By and large, if somebody has axial disease, it is exactly like ankylosing spondylitis. So you don't have a choice. You can't use sulfasalazine, you can't use a methotrexate for axial disease if you have psoriatic arthritis. So these are GRAPPA recommendation is use biologicals, whether you can, the preferred is anti-TNF, but you can use IL-17, or you can, this is not my this thing, today, but yes, just to complete the task, that anti-TNF, anti-IL-17 or JAK inhibitors can be used. For a peripheral arthritis, you can use conventional CSD-MARTs, you can use any drug, or you can use other biologics for peripheral arthritis. Basically, these are the drugs which you can use. For enthesitis, also methotrexate can be used, or biologics DMARDs can be used. For a dactylitis, also methotrexate and other drugs can be used. For psoriasis, we all know, generally it goes to most of the dermatologists. They use the CSD-MARTs and anti-TNF. I use mostly anti-IL-17. For a nail disease also, it was a learning to me that you don't use the CSD-MARTs. You use the biologic DMARDs for a nail disease. So exactly, a nail disease and axial disease in psoriasis, they are treated on a similar line. For IBD, the anti-TNF is used for IBD with the psoriasis, and for a uveitis, again anti-TNF is this is a summary. I'll skip. These are the summary of the presentation of EULAR and GRAPPA recommendation for the psoriasis. That if you really ask me, there's hardly any difference, except the GRAPPA says that you use the EULAR says the CSD-MARD you use first, methotrexate is preferred, that I'm talking about psoriasis, and then you use all these drugs, including anti-TNF, while the GRAPPA recommendation is you can use anything. So that is how these are the last probably 1 or 2 slides, that for Crohn's disease also, it doesn't come to us. Most of the time, the Crohn's disease generally goes to a gastroenterologist. But if you read these guidelines, anti-TNF agents, whether A, B, C, D, any one, should be used to treat Crohn's disease that is resistant to treatment with steroid. So the first line of treatment remains the steroid as well as the Crohn's disease is concerned. So that has a very strong recommendation, moderate level of evidence. Anti-TNF agent should be given for Crohn's disease refractory to methotrexate or thiopurines is strong recommendation. And anti-TNF agents, infliximab, Adalimumab, Sertraline, can be considered to treat severely active Crohn's disease is strongly recommended. So this is the anti-TNF therapy, especially these drugs, should be used to maintain remission of anti-TNF induced, just as we do in our arthritis. So these are the recommendations, which is probably the induction to remission. That is I think I have to summarize. Yeah. If you ask me, my own journey from 99 on ankylosing spondylitis, I know I don't say that we have treated many psoriasis, maybe 100, 200 psoriasis. But if you ask me about ankylosing spondylitis, that the clinical, with the anti-TNF, the clinical remission is definitely possible in most of the cases. Though people say there's a 40% failure, or I always feel hardly anti-TNF fail in ankylosing spondylitis. Very rarely. It does fail. If the infliximab fail, then you switch over to etanercept. If etanercept fail, then you go to golimumab. So that is most of the time you can achieve in 80 to 90%. But the most of the literature says they work only 60 to 70%. You use some other drugs like the secukinumab, anti-IL-17. But the clinical remission is definitely possible in most of the patients with the anti-TNF. The MRI regression is also possible. If the early disease, as we had most of the cases in army, because of the good referral system, we could achieve. But if somebody has developed syndesmophyte, somebody has developed the radiological regression, is very, very difficult. And probably as on today, answer is no. The radiological regression is not possible. If somebody has a bilateral sacroiliitis, radiologically, that regression is not possible. But MRI regression is possible. Radiological non-progression means somebody has a disease, and does it progress? Can this be stopped? Probably few studies says yes, but the doubt continues. We really don't know whether it does it. But most of the people say whether the paper from Harun or other paper says that if we use early, and our own experience say if you treat early, probably that is a window of opportunity. Whatever regulatory, the Western world is different because everything comes from the insurance, and insurance people had their own issues that they don't want that people should be treating over. The sacroiliitis, we all know that MRI sacroiliitis sometimes can be misleading. But if somebody, a good rheumatologist, experienced rheumatologist is there, and if they say it should be used, probably 99.9% will be correct. We all know we have done our own mistakes sometime. Recently, I had given a anti-TNF to a person during the COVID time where he didn't improve. So I was shocked. So I talked to then we realized that he had a severe hypermobility syndrome with bilateral sacroiliitis, probably because of the hypermobility. Hypermobility can cause bilateral sacroiliitis because normally sacroiliitic joint doesn't move. But in hypermobility, probably it moves a little bit and it causes osteoarthritis. We have all burnt our fingers, but that we can discuss in the question answer session. This was our first patient, which was, if for historical sake, if this video works, 2002. Just 30 seconds more. Thank you.
Thank you, Dr. Ved Chaturvedi, for sharing your personal experience as well as the current recommendations, especially with reference to ANG-SPON. I think one area where I think is, what is your opinion of using it in rheumatoid arthritis? I mean, it's quite.
Actually, I had initially, I didn't see the topic, so I had prepared for rheumatoid arthritis also. Today I saw it. So in rheumatoid arthritis, I was just wondering whether for rheumatoid arthritis, how much I have used. Hardly any, if you really ask me. For rheumatoid arthritis, you have plenty of drugs. 1, 2, 3, 4, 5, 6. So if you ask my own view, my own experience, my own experience, for rheumatoid arthritis, this much. For ankylosing spondylitis, this much. Probably for axial disease, this is the only drug. For rheumatoid arthritis, you have many drugs. But I'm very sure in this crowd, Dr. Joyce is there. You are there. You must be using more for rheumatoid arthritis. In armed forces is basically 1.2 million males. And doctors are also biased towards males because the females cannot be transferred from Srinagar to Delhi or from Guwahati to Delhi, but male can be transferred. So we had more number of patients except local Delhi rheumatoid arthritis. I must have used about 200, 300 patients of rheumatoid arthritis. But basically, if you really ask me my view about this thing, it is maybe inadequate.
Yeah, I mean, my personal feeling is I also have very limited use of anti-TNF somehow.
Though guidelines, I can always tell, I have read it today only, that you use methotrexate first. And if methotrexate fails, you can use other drugs. Otherwise, you can use anti-TNF. So that is simple, that we all know. And now, normally you have to wait for anything, any drugs which you are using it for DMARDs for 3 to 6 months. 3 months is to start the action and 6 months to achieve the target. So don't frequently change the drug. That you start the methotrexate, then after 2 months you keep changing. So probably that is very, very important, that you is to wait for 3 months if it is working, and then if it achieves target in 6 months, then you continue the same drug.
Dr. Mahendranath, any comments?
Yes. I don't think there's any other person in way to talk on
Thank you, sir.
TNF and ankylosing spondylitis, because it is he modified the Army's rheumatology unit completely and made it a center of excellence. RR Hospital, I've been there. And even Maini, when he visited, he had a grudging admiration. Apart from Ramnath Mishra, whom he admires the most, he had a grudging admiration for Ved Chaturvedi because he said, we cannot do all what Ved does in the Army Hospital in England, he said. So Ved has definitely a lot of experience on this. As he said, I think he's given a very realistic picture whether progression can be halted. I entirely agree with him. Yeah. Thank you, Ved. Thank you.
Thank you, sir. Thanks.
So I think, thank you, Dr. Ved Chaturvedi. We will move on to the last of the lecture, but it's a most critical lecture, because any drug we use, we work with the fundamental principle, do no harm. I think that being the case, I would request, though it's a last lecture, a patient's hearing to what Dr. Ramesh Joyce, who is a consultant rheumatologist at Manipal Hospital, Miller Road, and also Vice President of IRA Karnataka, who has several publications with a special interest in vasculitis, to speak about the safety of anti-TNF drug. Over to you, Dr. Ramesh.
Thank you, sir. Is my screen seen?
Yeah.
Good evening, everyone. And thank you, Chandrasekhar sir, for asking me to be a part of this wonderful meeting. So my talk today starts off from where the previous speakers left. That is, once you've decided to use an anti-TNF drug, what are the safety precautions and follow-up? And, as you keep the patient on treatment, what are the things that you're going to look for? So in a follow-up thing, one of the most important aspect is obviously safety. We'll talk a little bit about the safety part of it. And then you will also be seeing whether the drug is working in your patient. And then the question comes whether he has failed, what is your option, whether it's a primary failure or a secondary failure. And then is your treatment cost effective? A lot of the previous speakers have spoken about the cost being a big determinant in our country. And what are the ways you can bypass cost to help our patients to stay on these wonderful drugs for a longer time? And a little bit of my own interpretation of long-term continuation, particularly in the context of ankylosing spondylitis. So the first pivotal thing is safety. We all know that anti-TNF drugs are granuloma inhibitors. So one of the important things that you should be doing is to do a screening prior to starting patients on anti-TNF drugs. And this slide is more useful for the students who are listening. So a history of present or past tuberculosis, close contact with active tuberculosis, previous history of demyelination, because there are some reports of new demyelinating disease or exacerbation of existing demyelinating disease following the use of anti-TNF drugs. Patients in severe cardiac failure. Patients in NYHA 1 and 2 probably should be okay, but those with 3 and 4, there is data to say that there is worsening of underlying cardiac disease. There has been some debate about malignancy and anti-TNF. I'll briefly touch on that during long-term follow-up, but any recent malignancy in the last 5 years would probably be a relative contraindication. When I mean relative, it is important to understand also that an active untreated inflammatory disease, if you don't have any other option other than anti-TNF, and you have a malignancy that is fully treated about 2-3 years ago, I would probably still go for the drug. And a good clinical examination to look for any evidence of lymph nodes, chest auscultation, and relevant tests. And today, the relevant tests for us to screen for latent tuberculosis would include a chest X-ray, a MAN2, a TB quantiferon, or gamma interferon assay. A HRCT chest is a plus minus. We'll come to that. And important hepatitis screening and HIV screening is important because you don't want to exacerbate the underlying quiescent viral infection with the introduction. And if you did find latent tuberculosis, obviously you have to treat it adequately. We published this on our perceptions of what would be the right way of doing latent tuberculosis screening in India in 2017. This was published in the APLAR journal, and I was a part of this group which did it, and Dr. Handa being the first author. So if you had somebody with a chest X-ray that is positive, you would consider straight away active tuberculosis and you would treat it. If the chest X-ray was negative, you would do tests for latent tuberculosis. You would do both MAN2 as well as IGRA, and if either of them were positive, you would look for active chest lesions. If there was an active chest lesion, you would treat. Otherwise, if it is negative, you would go for treatment of latent tuberculosis. The CT scan of the chest can be put in anywhere here. It is not mandatory, but if you have a slightest of the doubt, it is better to go for a CT scan to rule out active disease. What therapy would you use for latent tuberculosis? Although the WHO recommends 9 months of INH or 4 months of rifampicin, ideally, I would say INH plus rifampicin, especially for India or high endemic countries, in view of the high prevalence and the worry of drug resistance. So conventional practice is to use a combination of these 4 weeks prior to, and then continue to be on this drug for 4 to 6 months while on the anti-TNF drug. So this is what you would do. Tuberculosis occurring in the context of anti-TNF therapy has been significantly reduced by doing these screening tests and putting patients on latent tuberculosis treatment. However, when it does happen, tuberculosis could be extrapulmonary or it could be disseminated tuberculosis. And this is one classical example of my patient who previously had a genitourinary tuberculosis adequately treated for 9 months and then went on to have infliximab, mainly for Behçet's eye disease. But unfortunately, and screening tests were negative at the time of initiation, but developed massive miliary tuberculosis. Amongst the various anti-TNF drugs that we have, it is always believed that infliximab and adalimumab carry the highest risk of tuberculosis, while etanercept, because it does not work or act on the TB granulomas, has the lowest risk. However, caution is very important in patients in countries like India, which has high endemicity. This is one of my patients who had rheumatoid arthritis, who was on etanercept, developed disseminated tuberculosis. You can see tubercular tenosynovitis. Okay, and we curated these granulomas, and they were strongly positive for acid-fast bacilli. and 6 months of anti-tubercular therapy cured this patient. So it's important to bear in mind that when we say that the incidence is low, it does not mean the incidence does not, that tuberculosis does not exist. The frequency is low. So maybe in your choice of therapy, when you have somebody who's been treated for tuberculosis in the past, maybe etanercept amongst the anti-TNF drugs may be a better option compared to the other three drugs. So we also from the Karnataka Rheumatology Association had our own KBC, that is Karnataka Biologics cohort, and we looked at the risk of tuberculosis in autoimmune rheumatic diseases. And Dr. Vinita Shobha was the first author in this paper. So we looked, this was a retrospective study that looked at 195 patients treated with biologics. 21 of them were treated for latent tuberculosis. 7 patients developed TB. And this was despite having negative screening tests. So caution is important, but at the same time, panic is not required. And with continued use, I mean, in private practice, I have used biologics, especially anti-TNF drugs, extensively. And, going on further with the previous discussion of using it in rheumatoid, I have used it quite extensively in rheumatoid arthritis. I have a lot of patients on adalimumab as well as etanercept, and in the earlier days on infliximab, and I hardly came across tuberculosis. My patients in this series were only 2. So, it is still by and large a safe drug provided you follow precautions. The other important thing, because this is a big immunosuppressive agent, was the worry of serious infections. By now, we have a lot of accumulated data from clinical trials as well as from real world, from registry data. And this was a long-term study in children with GIA, which looked at serious infections. I was shown that there was no significant difference in the risk of serious infections in patients receiving TNF inhibitors compared to those receiving placebo. So this was also comparing the various other drugs. This was about comparing various other drugs to say whether one drug was better compared to the other, and the relative risk was lower in etanercept and higher in infliximab and adalimumab. And this is in spondyloarthritis patients from one of the, this is the German cohort, which had a collection of patients with various types of spondyloarthritis. And it was shown that the risk of infection, serious infections in spondyloarthritis patients treated with anti-TNF inhibitors was very low. And what influenced this was steroid use and age at the start of concomitant steroid use and age at the start of TNF inhibitors. That is, elderly age group had a higher risk compared to younger age, and this could probably be also due to age-induced immunosenescence as well as the coexisting comorbidities. And corticosteroid use was associated with a higher risk of infection, that is combining steroids with TNF drugs. The risk of serious hospitalization was looked at also in patients with autoimmune disease. It was shown that in this cohort of patients with psoriasis, psoriatic arthritis, and ankylosing spondylitis, that the risk of hospitalization was not increased due to serious infections. And this was data from the British Biologics Register, which just showed a very marginal increase with all anti-TNF drugs compared to traditional DMARDs, but the risk was not very high. So this was our, once again, Karnataka rheumatoid arthritis cohort study, which was a multi-center cross-sectional retrospective observational study, of which Dr. Chandrasekhar was the first author, which looked at 209 subjects with rheumatoid arthritis. And amongst the patients who had a biologic DMARD therapy, 13.8% developed infections, and a majority of them had only minor infections. So this is a very important piece of information published from India. So despite our hygiene, despite our comorbidities, our co-prescriptions, still the risk of infections is low in Indian patients who have been treated with biologic therapy. While we always look for expected complications amongst anti-TNF users, I have also earlier alluded to occasional instances of demyelination, worsening of cardiac failure. But I just want to bring you one of my patients. This is a real life who had another rare complication. So this was a 33-year-old male angstbound of 15 years duration who had a partially ankylosed spine and a severe right hip arthritis. He initially received infliximab between 2009 to 12 with secondary loss of efficacy and switched over to etanercept. From 2014 to present, he was on etanercept, and gradually we had reduced his dosage, and he was only on once a month and was doing extremely well with a BASTI of 1.2. Presented to Abhishek Patil, my colleague rheumatologist, with fever and shortness of breath, and an echo confirmed pericardial effusion with tamponade. Infections were excluded. Routine tests were normal, high inflammatory markers, reactive mesothelial proliferation on pleural biopsy. So the differential diagnosis here, as you can see, the chest X-ray which shows cardiomegaly and a left-sided effusion, and a CT scan which shows a right-sided effusion as well as a left, so bilateral pleural effusion with a large pericardial effusion. So the differential diagnosis would be infective versus viral, but one thing you should always remember is drug-induced lupus, which is a rare thing. In good old days, when I practiced in England, before we started anti-TNF therapy, when they were first introduced, we would conventionally do an ANA in all patients, but that practice was discontinued later because of the rarity of this problem. This patient, after using anti-TNF for this many number of years, developed a drug-induced lupus. He was strongly positive for ANA and double-stranded DNA. His etanercept was discontinued. He was started on steroids with complete improvement, and a molecule of a different mode of action like secukinumab was started, and he's doing well. And I'd like to thank Abhishek for sharing the pictures. So there was one debate in the past about the risk of malignancy. So this was also an important safety issue, given that now the most guidelines advise you to keep patients on anti-TNF therapy long-term, because the risk of relapse is very high when you stop them after using, especially in axial spondyloarthritis. So this is data from etanercept open label trials from JIA and registry data, which showed that malignancy rates were very low. And in the same thing studied in psoriatic arthritis across various biological drugs. All the 4 anti-TNF drugs showed that biological DMARDs do not lead to an increased risk for cancer development. So, however, vigilance is always required from our side, because this is an important question that a patient might ask you when you are counseling them for a biologic, because when you put in anti-TNF drugs on the net, you can find talk about malignancies. So one of the important aspects when it comes to anti-TNF therapy is about continuation of therapy, how long to continue. Because in the past, cost was a big constraint. Now with improved quality of life, better earning, and a lot of patients can earn better now. And even in private practice, where the cost of therapy has come down, some of the brands of adalimumab are now available for 5,000 rupees an injection. When we started off, it used to be about 14,000. So how long would you continue therapy? So this is retention rates. Once you start on patients, the retention rates from published literature says that it is just over about 50%. So 50 to 60% would be the retention rate for a first biologic. Whereas once the patient fails a first biologic and you start the next biologic, the retention rates start dropping. And that holds good both for axial spondyloarthritis as well as psoriatic arthritis. And this is data from the Italian registry, which compared children with non-systemic GIA versus adult with other rheumatic disease. And it was also shown that retention rates were similar, the behavior was similar in both adults and children, but probably because these are injectables, the dropout rates were much more in children compared to adults. So what are the causes for non-adherence? So when you come to non-adherence of with such a good therapy, one of them is treatment failure. The treatment failure could be primary, where just that the drug may not work, or secondary, that it works after some time, like how I showed in my patient with Einspond. After at least 6-7 years, infliximab stopped working. So that's secondary drug failure. And then you have toxicity, and then healthcare utilization and related costs. And then comes personal choice, which is a very important aspect, which comes when we talk about patient-centered care. So one of the important problems with monoclonal antibodies is anti-drug antibodies. And this is more common with adalimumab as well as infliximab. And one of the worries in the diseases like spondyloarthritis or rheumatoid arthritis, where these drugs were used, was the development of HACA antibodies. It was shown that the HACA antibodies reduced the effectiveness of the drug, and those patients who had drug antibodies had lower ULR responses. So one of the effective ways to counter HACA antibodies would be to combine methotrexate, and it has been shown well in studies that when you combine methotrexate along with adalimumab or infliximab, irrespective of the indications you use these drugs to treat, the probability of HACA antibodies is reduced, and so also secondary failure. Skip this. So next comes the question, because of cost constraints, and we had a long debate about radiographic inhibition, would it be beneficial or would it be rational in continuing these drugs in the long run? So if you were to continue, how would you negate the cost of long-term therapy? Because the treatment that you continue long-term should have scientific evidence. It should also be not just evidence-based, but it should also be cost-effective. So what cost-effective strategies can you employ in the long run when you have patients on anti-TNF therapy? So anti-TNF therapy, in addition to improving clinical outcomes like BASDI and BASFI, was shown to improve radiographic outcomes, particularly MRI. And Dr. Chaturvedi mentioned about this. And this was one of my patients who was treated with infliximab. You can see multiple lesions in the spinal cord, inflammatory lesions, and the same majority of them disappearing after 6 months of infliximab. So we briefly, Dr. Chaturvedi also mentioned about Nijil Haroon's paper. Now, there are two important messages out of this. One, Dr. Chaturvedi mentioned that the treatment has to be started early, because early treatment determines everything. Why is this important? Because if you have inflammatory lesions and you treat it with an anti-TNF drug, the chances of inhibiting radiographic progression is high. When these inflammatory lesions get converted to fat metaplasia, we now know that osteoproliferation is very prevalent in lesions which are fat metaplasia rather than those lesions which have active inflammation. So hence, it is important to inhibit in the early stages, that is the inflammatory stages, rather than by the time it is more than 10 years where half the lesions are now fat metaplasias. And that is why you may not see radiographic inhibition by the time you reach this 10-year or more than 10-year period. Another important thing is when you look at data progression, the initial data came at when anti-TNF drugs were compared with a historical cohort called OASIS cohort, where the treatment was given was only for 2 years for biologics. Then the pivotal question comes, is 2-year therapy enough to inhibit radiographic progression? And an important question was answered by Nijil Haroon's paper, that the difference between X-ray should be more than 4 years to show inhibition of radiographic progression, which once again says that if you decide to choose an ankylosing spondylitis patients, aim for long-term therapy, aim for therapy which is going to be beyond 4 years, or long-term continuation is very important. And Esther trial also showed similar outcomes, both in terms of clinical outcomes as well as MRI outcomes, that 60% of the patients achieved remission at 3 years. And this is a very recent publication, which was a structured literature review of 23 studies, 11 open label extensions and 12 cohort studies. And the dotted lines say patients who are not on therapy, whereas the colored lines show long-term therapy in years, and it has been shown that continuing anti-TNF therapy long-term over years is important to inhibit radiographic progression. Now, what is the other additional advantage? You heard Professor Peter Taylor discussing about cardiovascular risk in the recent talk. So this is a slide showing continuing long-term reduces not just the morbidity associated with the disease, but also mortality. So what are the issues and challenges? One is about lengthening the time intervals. So how can we achieve making patients stay? So this is a study that looked at psoriatic arthritis patients. So rather than reducing the dose of etanercept, lengthening the treatment duration, instead of 1 week, make it 2 weeks, make it 3 weeks, and keep the patient as long as he's in remission. And we also published this data. This was one of my initial days in the United Kingdom about low dose infliximab. We used the 3 milligram per kilogram dosage as used in conventional rheumatoid arthritis instead of the recommended 5 milligram per kilogram, and demonstrated that in majority of the patients, you could sustain the effect of infliximab in the long run on the low dose. Following this came the CANDLE trial, which showed that 60% of infliximab treated patients could still be maintained on a lower dose. And low dose etanercept, this is answering Dr. Vijay Rao's earlier question about what is the data that would say lower dosage of etanercept. This trial looked at etanercept lower frequency rather than dose. So rather than giving every week, every other week was equally effective in patients with ankylosing spondylitis. Finally, the last part of my slide. A lot of our patients are in the reproductive age group, because obviously when you're continuing biologics in the long run, reproduction becomes very important aspect of treatment. So obviously when you're exposed to biologics, what is the risk? What is the safety? So safety to the newborn and the mother is very important. So this paper looked at paternal exposure to immunosuppressive therapy and or biologic agents and birth outcomes in patients with immune-mediated inflammatory disease. And the conclusion was exposure in the father or paternal exposure to immunosuppressive and or biologic therapies during periconception did not risk the adverse neonatal outcomes. And hence, if you see the latest recommendations, paternal exposure is okay for almost all disease-modifying drugs, except an occasional one like cyclophosphamide. But otherwise, paternal exposure is compatible to almost all. Next comes maternal exposure. If you have a mother who has very severe disease, who's on a biologic drug, what is the current recommendation? This is the latest British Society of Rheumatology guidelines published in 2022. And if you select only the anti-TNF drugs, pre-conception, everything is compatible. First trimester, everything is compatible. But infliximab, it is advisable to stop after 20 weeks, adalimumab and golimumab 28 weeks, and etanercept 32 weeks. And this is to prevent antibody transfer to the fetus, and because the baby is going to be exposed to live vaccines in the first 6 months. But if there is a clinical situation where the drug has to be continued and the mother has uncompromising, very severe disease, then these drugs can still be continued into the 3rd trimester, but then you should postpone live vaccines for 6 months in the neonate. Breastfeeding, these drugs are definitely can be continued. So real life situation throws a lot of challenges in patients who are on long-term therapies. The constraints of time, I have just chosen a few of them. One is about the need for continuation. 2 is the safety. 3 is the cost effectiveness. And 4 is about pregnancy. I thought these were the 4 important aspects I had to cover. So this is my final slide. In summary about anti-TNF drugs, long-term efficacy and safety is very well established. Latent tuberculosis screening significantly reduces the risk of tuberculosis, even in high endemic areas, as we have shown in Indian publications from our own group. Serious infections are less, so not to worry. Strategies for long-term continuation, especially in India, need to be evolved. More innovative strategies are required. The strategies I practice in clinical practice is I don't reduce the dose of the drug, but I just widen the gap between the infusions or the injections. Anti-TNF drugs still have a very important place despite tofastatinib. Tofastatinib may be cheap, tofastatinib is generic, widely used, but in the context of axial spondyloarthritis, the inhibition of radiographic progression data is not robust in tofastatinib. Anti-TNF definitely has an edge in the fact that it has been used for a long time, and we have wired data for more than 25 years. So if cost is not a constraint, I would prefer anti-TNF drugs over tofastatinib in axial SPA, especially in those patients who show signs of progression to avoid radiographic progression. Thank you very much. I'm more than happy to take any questions if you have any, and I'll log out.
Yeah, thank you, Dr. Ramesh, for a very nice coverage of three critical aspects which I was looking forward for. The safety have really made a very balanced mention that, of course, though infection is a worrisome thing, it's not that all that we need to be so worried about. If you take due caution, especially if you screen for TB, screen for infection, and be vigilant about any possibility of a serious infections. And also you have dealt about few of the areas where long-term continuation, preferability, etc. I think now the forum is open for questions and discussions.
I think safety is because the two things patient will ask me, all of us, the cost and the safety. In fact, safety first, because everybody has told these are unsafe. So very nicely covered by Joyce. I can tell you, I still feel after, we all have used for many years now, all of us, that etanercept remains the leader. Why etanercept could not compete with adalimumab? Because of Americans' preference for Humira. For whatever reason, I don't say it's a commercial reason or something, but today in private practice, if I'm sitting and if patient comes and tells which one I can use, whatever you say, so I'll say you can take etanercept first. And if I develop ankylosing spondylitis, if I have to use, I'll use the safest, that is etanercept. And if I can afford, golimumab, because golimumab is also safe, absolutely safe, absolutely effective.
Sure.
Ramesh, excellent talk as usual. I think it was again listening to Peter Taylor, like you see. No, you see, I have used my experience of infliximab in RA patients in the initial years. I used it. I remember very well about 17 patients, and I used the loading dose and all. Not a single patient developed tuberculosis or any other problem. But ankylosing spondylitis, spondyloarthritis, first few, and most of my complications have landed with you when I'm out of the country, and particularly the difficult doctor from Tirupati, Why is this? I mean, out of first 11 spondyloarthritis patients, 2 of them ended with tuberculosis. But I never had. I mean, is it just I'm lucky that it didn't happen in rheumatoid patients, or is there anything else happening?
Yeah. So since I've seen all your patients who developed tuberculosis, I think it is plain coincidence, sir. I think there was nothing different. You had done all the necessary screening tests. Okay. The only thing I can remember is maybe the doctor from Tirupati was big, and he needed big doses of infliximab, and it was close to 5 milligram per kilogram. Whereas your rheumatoid patients were all comfortably on 3 milligram per kilogram. That is only on one patient I can tell, but otherwise, I think it was just a mere coincidence since I've seen all your patients.
So I can tell you from Ved's assertion that 3 milligram also acts better.
Yes.
Sir, I'll tell you the 3 milligrams, certainly you don't require 5 milligrams for ankylosing spondylitis, where the inflammatory burden is low. In rheumatoid arthritis, probably because I don't have experience, but in general term, I feel rheumatoid arthritis has a more inflammatory burden. Ankylosing spondylitis has less inflammatory burden. You can use 3 milligrams for ankylosing spondylitis. Without loading dose, it will work. For rheumatoid arthritis, I don't know. But you tell me, all people are there, senior here. The patient only asks one question. And as a doctor now in practice, earlier I was in army, I always feel it should be safer. One patient otherwise was quite difficult. I'll tell you that story is different. That first thing is I normally avoid admission. So infliximab requires admission, at least in daycare. So the etanercept gives me advantage that I don't need, he does not need admission. Then tuberculosis part, I said, adalimumab has the maximum tuberculosis. If you really ask me today, my maximum number of patients, if I have tuberculosis, was because of adalimumab. Now, etanercept, first thing, it does not require admission. Then the biggest problem with us is we lose control. If he learns this is a drug, he does not come to you. So that you have to work a little smartly, that you have to show every month to me, and that should be conveyed very nicely, because if you're using infliximab, then control is with the doctor. If you use subcutaneous, the control is with the patient.
I think a few points with reference to safety and the TB screening is, I think I'm shortly sharing the data of my center with more than 150 TB screenings which we have done. Most of the time, the TB, even our own data, which we have published also from KRA, shows that TB flares are more in the group who are TB test negative. Both Manto and quantiferon are negative. And one of the serious concern in that is that there seems to be a false negative, and that's one of the major concern. And I was trying to work up with the number of patients I had, that is there any way we can pick these patients with any other additional screening processes like questionnaires, any other things. The number 120 I had in the last 2 years was too small to get any analysis. Probably, I think some effort is required from all of us to get these data, because I think I calculated the sample. We need around 5,000 to 8,000 screened patients who have been exposed and have developed at least 2% of incidence of tuberculosis to calculate and figure out the predictors, which I think should be of some great help in those patients where TB quantiferon comes negative, and so that we can pick them up, because we can also start these patients with anti-TB prophylaxis, because anti-TB prophylaxis has really made a difference, because the patients who are positive, we are bold enough to start a TB prophylaxis, which we don't if it is TB test negative. I mean, that's where things gets missed.
A lot of people from other departments says, if you're giving this, then there will be resistance to the Isonex or so. I don't know the answer. I'll just ask you, Chandrasekhar. You tell me if they are very against the.
We are following the WHO guidelines also. Even the WHO says the same thing. There is a standard guideline for latent tuberculosis prophylaxis. And you can refer, if they want, they can read up our review, which Handa sir and we all were part of that group, which wrote up. And that has been widely cited.
No, they quote one thing. They quote Indian studies of resistance where tuberculosis drugs were given unnecessary. They say this latent tuberculosis concept is a Western concept. If you attend those meetings of those Tuberculosis Society of India and all, a lot of discussion on latent tuberculosis and anti-TNF, and even the people who are using the chemotherapy and all. So they are very against using the anti-TNF, anti-tuberculosis as a preventive measure, which we are using. We have standardized it, but a lot of people, those who are treating tuberculosis, they are against it. So your views about that?
I think even I would disagree on what they say. It is very clearly shown from good published literature that testing latent tuberculosis, treating seriously, because the tuberculosis, what you see otherwise, is different from the tuberculosis we see with anti-TNF therapy. It is unusual locations, widespread, disseminated. Many times it takes a while to pick up the tuberculosis itself in weird locations. So the type of tuberculosis we are going to see with anti-TNF therapy induced tuberculosis is going to be very severe, very atypical. So I don't think I would buy that.
I'll ask another question. Tuberculosis is endemic in this country. Well, it is not endemic in the US or other countries. Is there anything which can, these guidelines can differ? Especially the diagnosis of latent tuberculosis.
Yeah, as Dr.
Chandrasekhar was also pointing out.
Yes, yes. As Dr. Chandrasekhar was pointing about, as of today, we don't have any other sufficient screening test for latent tuberculosis. So till we get a better screening test, we could add that up as, another one to our existing ones. We all know MAN2 has its own, advantages and disadvantages. We know that the background prevalence of quantiferon gold positivity itself is high in our population. So previous BCG vaccination is known to influence MAN2. So there are many things, and the insufficient use of the PPDs. Each lab does a different type of PPD test. You can get a lot of false positives, false negatives, everything because of that. So despite all that, I think with whatever we have, we should still screen.
No, I think the screening is the best way to go. I think it's beyond doubt. It is.
The only thing I think it should be added is probably, I feel so, that sometimes we have burnt that X-ray chest is normal, but a CT had lymph nodes. So if somebody especially had a smallest doubt, and today the people take you to the court, and also if you have doubt, get a CT chest. CT chest probably will show you more.
There were different algorithms for investigating latent TB in India. And a few years ago, Malaviya sir had published one algorithm, and his algorithm recommended a CT chest in all patients. Now, I mean, that is economics once again. Whether you're able to afford a CT chest in all of them is a different ballgame altogether.
That's a bit expensive. That's of course.
Chandrasekhar, I have one question. See, most of this TNF-induced tuberculosis, at least as far as my knowledge is concerned, is multi-drug resistant. Is it due to endemicity of the disease or anything else?
It's not necessarily, sir. Actually, if you look from the reference codes that what we have from India, it's not really they are drug resistant. They are actually atypical presentation, as Dr. Ramesh was telling. It usually comes at multiple sites and in a site which are unusual. And they are more comes like a disseminated type of tuberculosis. We catch it slow and little difficult to treat. Not because they are MDRs. It is actually not a correct way to expect a MDR unless you have a pre-existing MDR as a latent tuberculosis, because most of the latent tuberculosis are not necessarily the drug resistant.
And a very unusual case, which I was mentioning, a radiologist from Bhopal, she had a unilateral sacroiliitis seen by a very qualified person, and she was given the anti-TNF, golimumab, that was safest one, and she flared, and she had tuberculosis everywhere, and she was admitted with vomiting and big granulomas in the brain also, not only the lungs. So lungs, brain, everywhere. So then they sent to me, what else I could have done? I just saw the X-ray, the CT scan of the SI joint, and we have a very good department of internal intervention radiology. So we did a biopsy of that unilateral sacroiliitis. It had tuberculoma. So we really don't know whether it was initially tuberculosis or HLA was negative. Probably this girl, who herself is a doctor and radiologist, had a unilateral sacroiliitis. Probably it was from beginning, it was tuberculosis. So probably that is also there.
So actually, MDR we don't see so much. If I think it's as much whatever the TB flares I had, none of them were MDR. Most of them were responsive to the routine care.
I agree, sir. Same experience here.
And same, you said, you showed one case of internalized disseminated tuberculosis. I also had only in last, say 23 years, 24 years of use of biologics, I had one patient disseminated tuberculosis on internalized.
Yes, that was my only case. So
I but adalimumab, I can tell you 1, 2, 3, 4, 10, 20 cases. And then I realized, no, adalimumab, hardly used for this region only, not for any other.
I have seen around 20 to 25 tuberculosis post.
On adalimumab. Yeah, so adalimumab definitely has.
No,
and
one all biologics put together.
Okay. Mm-hmm.
So most of them, I think that's why I was bold enough to say to Dr. Mahendranath that none of them were MDRs, what I saw. So
one malignancy was there in tuberculosis with the Brigadier Saab, which I sometimes show that slide. And in the beginning, somebody was against this thing. No. The loading dose we'll use. So this patient had come from Chandigarh, and Brigadier Saab for rheumatoid arthritis, loading dose of infliximab, given everything, and then developed a swelling in the axilla. And at that time, we were learning ultrasound. So I put a probe of ultrasound on the axilla, big lymph node. So I was see tuberculosis. So I put a needle, aspirated, sent to then from the OPD itself. I was very sure it is tuberculosis. The report was malignancy. That was the only one malignancy. We really don't know. It had to happen. But as Ramesh said, things have been settled now. Malignancy does not increase with the anti-TNF. Infection definitely.
Just by chance. Actually.
Yeah.
Yeah. Any other questions from other participants? Here. Right. I think we are almost close to 8:33. I think we are 30 minutes past the time scheduled. I mean, it was very interesting discussion. I think all the lectures were very enlightening. I should thank all the faculties.
One more thing I just want to add. So, because even if one person is listening, even we four are listening, this is very important. Twice I have burned my finger. One patient from Guwahati came, again seen by good people, and not responding to anti-TNF and not responding to IL-17 or something. They came. I was just thinking what to do. Maybe I just got an X-ray, got a fracture there. So this I rang up and told him. But hardly 10 days back, I did a mistake. Similar kind of patient came. He was not responding. He was having pain. I switched over to the IL-17, sent back, but his pain was not improving. He went to a orthopedic surgeon who took an X-ray and diagnosed fracture, and he rang me up and said, this is a fracture. So fracture sometimes you miss, especially in advanced disease.
Other one is a metabolic disease which you miss sometimes. So I think I should thank all the faculties, Avinash Jain, Vijay Rao, Dr. Ved Chaturvedi, and Dr. Ramesh Joyce for a very wonderful lecture. I thank all the participants, and especially the inputs from Dr. Mahendranath has invoked a lot of discussions. I thank all the viewers. I think more than 200 plus were online at this point of time. Hopefully they have enjoyed all the lectures, and this will be available for another 1 year. So anybody can revisit and go through the lectures to make it interesting. Probably we will be rolling a few of the MCQs, which can help in preparing for the exams. I think with that small note, I thank all of you.
Thanks for the honor. Thanks, Chandrasekhar, for the honor. Thank you so much.
Thank you.
Thank you.
Next talk is going to be on anti-IL-6 strategies. So shortly we'll have.
I was quite nervous about the whole thing because of what technical issues, and also it was very difficult to. Thanks. Thank you so much.
Thanks. I think we'll